So good afternoon everybody. Today we will talk about urinary tract dilatation. Okay, so there is a lot of dilemmas regarding urinary tract dilatation. I have just picked up 10 important dilemmas which we will try to answer throughout this presentation. Okay. Now always urinary tract dilatation are subject to confusion, but hope so after this presentation we will sort out all those confusions. Now whenever we see urinary tract dilatation, the common denominator is hydronephrosis. As you can see in all these pictures, there is dilatation of the collecting system. Now once there is dilatation of the collecting system, we need to answer certain questions which we will be seeing in the subsequent slides. But for your information, all this dilatation are consequent to obstruction at different levels. The first one is at the level of pelvic-ureter junction, the second one is at the level of vesico-uretary junction, then there is a duplex collecting system, then ectopic ureter, vesico-uretary reflex, and then there is these two are lower urinary tract obstruction. One is because of the urethral agenesis and other is because of the posterior urethral valve. Now these all conditions I will discuss later on in my presentation, but the idea is that you should be acquainted that whenever there is obstruction at various level, the common denominator is you get dilatation of the collecting system. So dilatation of collecting system is not a diagnosis, it's just a sign. It's just a sonographic sign, like ventriculomegaly. It's just a sign. Once you see the sign, it should trigger you to look into detail to find out why is that sign present, what is the probable cause explaining that sign. Now there are three things when you see this: cause of obstruction. What is the cause of obstruction? We are not at all good at cause of obstruction. We don't know. These mostly are a postnatal diagnosis. Next is the level of obstruction. Level of obstruction, yes, sometimes we may predict, sometimes we may not predict. But at least level of obstruction, to some extent, we may predict. Third is effect of obstruction. So what we are actually picking up is effect of obstruction. Rest of the two we are not picking up really very great, but what we are picking up is effect of obstruction. There is somewhere obstruction downstream, and because of that there is a upstream dilatation that we are picking up on ultrasound. Now there are signs of many underlying etiology with variable outcome. I have discussed this. Now there is a rule of third I will discuss with you, but before that, 80% cases of urinary tract dilatation or hydronephrosis, but we will avoid terminologies like hydronephrosis, pyliectasis and all those. So we will talk in a common language of urinary tract dilatation, and if the antero-posterior diameter is 4 to 8 millimeter, so this is mild, and in mild category 80% resolves. Okay, but when you go to the severe end of the spectrum, when the antero-posterior diameter is more than 9 millimeter, only 15% resolves. So this is the data, like when you are counseling the patient, when scanning, you have to tell them if it is up to 8, most of them resolves. They are physiological, transient. But once it is more than 9 millimeter, the chances are only 15% will resolve. So you have to tell. And what is the rule of third? 1/3 of prenatally detected urinary tract dilatation will resolve before birth. 1/3. But these 1/3, most likely they are in this category of mild. Okay. 1/3 resolves postnatally, 2 to 3 years. So there is still hope that postnatally also resolution takes place. And 1/3 persist. And this persistent urinary tract dilatation will end up in congenital abnormality of kidney and urinary tract or urinary tract malformations. Right? So 1/3 will resolve prenatally, 1/3 postnatally 2 to 3 years, and 1/3 persistent, which may convert into Charcot. Now if you look into the etiology, 80% of the time they are transient. Transient means they are physiological and mostly they are self-limiting, and there is very high chances they resolve prenatally or immediate postnatally. In 20% of the cases, you will have all these conditions which I have shown you in the first slide. All the levels of obstructions, including lower urinary tract obstructions. In this, if you carefully see, one urinary tract dilatation is 1 to 3%. It's the most common findings encountered in the antenatal ultrasound. So whoever is scanning here in this room, if you analyze your data, on a consistent basis you are seeing this urinary tract dilatation, which we report in different terminologies. 20% is moderate to severe hydronephrosis, and 80% there is incidence of postnatal renal pathology. Now coming on to the 10 dilemmas, first is the anatomical landmark. Now why there is dilemma in the anatomical landmark, that I will show you, but before that just let us recap the anatomy of the kidney. Okay, you know, there is just focus on the green zone in all the diagram. So here the green zone is capsule cortical parenchyma. We cannot differentiate capsule from cortex and cortex from parenchyma. So these are a complex, capsule, cortex, parenchyma. Then there is peripheral calyceal system, the green one you see, this peripheral calyceal system. We should avoid calling minor and major calyces. Okay, peripheral calyceal system. Then there are medullary pyramids here, and then there is central calyceal system as shown in this. Okay, and this is again a composite diagram where you can see all the structures as labeled. So these four we will be dealing very often. That's why I have put up here that you should understand where is your cortex, how it looks like, how your medullary pyramids look like, and what are minor and or what are peripheral and central calyces. Okay, now how to translate them in our imaging, that is important. Okay, so when you look at the ultrasound, the picture of the kidney and the gray scale, you have all this checklist. You have capsule, cortex, the hypoechoic zones which is labeled, that is pyramid. Sometimes you may get confused that pyramids are dilated collecting system. That is normal, physiological. Pyramids look like that, hypoechoic. And then you have sinus fat as an echogenic hilum, then renal pelvis. So all these structures you will see in the normal kidney. Now where are calyces? Just before this slide I showed you where are their peripheral calyceal system, central calyceal system, but in a normal physiological state in the kidney you don't see calyceal system because they are compressed. They will only be evident or pop up when there is dilatation of those calyceal system in the pathological state. Otherwise normally they are in a flaccid state, they don't pop up, you will not be able to see. Okay, so don't worry about them in a normal situation. Now what constitutes the renal collecting system? So renal collecting system is composed of your renal pelvis and the calyceal system. Calyceal system again central calyceal system and peripheral calyceal system. So I will just explain you how they look like. Say this is the diagram of the kidney, and these yellow rounded things are medullary pyramids, and then you see the renal pelvis. Okay, this is all about renal pelvis. So any dilatation you will report as renal pelvic dilatation. Now this is again reniform kidney, this is medullary pyramids, and now you see some outpoaching, ballooning. This is a central calyceal system. Okay, so now there is dilatation of the renal pelvis and also there is prominence or dilatation of the central calyceal system. Now from central calyceal system there will be further branching which will be touching the pyramids. Those cuppings or the branchings or balloonings, these are the peripheral calyceal system. Are you getting me? So these are the diagrams, corresponding diagrams. This is the renal pelvis. Now just that from the renal pelvis, little bit this outpoaching is your central calyceal system. And once you enter into the central calyceal system, and these are your medullary pyramids. Okay, so this invagination into the medullary pyramids, these are is your peripheral calyceal system. why I am stressing on this, because this is a source of confusion, and your grading or staging of urinary tract dilatation will change. If you are saying peripheral calyceal system, it will become some other grade, and if you are saying only central, it will become some other. So we will discuss that as we go on, but this concept should be clear. Now I will just try to show you on a real time picture so that you get a better idea of this. Now you see this is the dilated collecting system, and then you see this outpouching. Now this is the renal pelvis, okay? And then from renal pelvis you see this is a central calyceal system, and then from central you see this peripheral, but these are the peripheral calyceal system. So just follow this renal pelvis, then it goes into the central calyceal system, and then it goes into the peripheral calyceal system. Now this is just a cast of the same renal pelvis, then central, and then the final ballooning, the peripheral ones are peripheral calyceal system, and this is again the picture showing the same thing. Now dilemma 2 regarding the definition, which one to adopt. Now what is the correct terminology? There is lot of confusion. So these are all different terminologies which we use. Hydronephrosis, some will say is pelvictuses, some will say it's urinary tract dilatation, and some will say no, it's urinary flow impairment. Then there is pileectasis, then there is pelvic calyectasis. Are you getting me? So these are all different terminologies people are using, and we are actually not able to comprehend what the other person means. That is why the classification of UTD came, urinary tract dilatation, so as we all speak in a common uniform language. So whatever I mean, I report, you also understand the same thing. So from here onwards we will not use any one of them, and we will talk on a common language of urinary tract dilatation. Okay. Now standardization. The most important thing before we even embark on this journey of urinary tract dilatation is how are we going to measure it? What is our landmark for measuring? Now I will just show you the summary. This is your renal outline, and this is your renal pelvis. Now you can measure at this point, you can measure at this point, at this point, at this point. So all these different levels you can measure, but exact measurement will be at this point. Okay, so it has to be in the widest part and the intrarenal portion, but I will come back to this intrarenal and extrarenal concept. So most of the time the measurements I will show you in that real-time picture also, but you have to measure from inner to inner in the widest part, and not in this kind of kidney. This is just a scheme to show your kidney should be at 12 o'clock position or at 6 o'clock position, and then your renal pelvis will be just like a equal to. I'll just show you a little bit of the abnormality. Now you see this. Can you see this picture? This now there is a role of sagittal and coronal also. In sagittal plane you will take the measurement of the kidney, bipolar length of the kidney, because that also has to be documented when there is abnormality, whether your kidney is within the normal range, the size, or it is 2 standard deviation or 4 standard deviation above. So the nomograms are there. So whenever there is renal abnormality, you have to measure the kidney, biometry of the kidney should be done, and it should be compared with the nomograms. So the measurement you will do in the sagittal plane, okay, and in this axial plane you will do the measurement of the renal pelvis. And also when you talk about the calyceal system, whether it is peripheral calyceal system, central calyceal system, those things will be better demonstrated on the sagittal plane. Okay, again just to show, these are the transvaginal scans. Okay, these are the transvaginal scan, and in this you see the renal parenchyma will be little bright, okay, because of the high resolution which we are using. Can you see this? Yes. Renal parenchyma is bright. That does not mean it's bright kidney. It's just because of the resolution which we are using, right? And if you have to measure the renal pelvis, that is the exact point. You have to freeze this and you have to measure from inner to inner. This is just to show where to measure and how to measure, the standardization. But also don't be overwhelmed by seeing the renal parenchyma being echogenic, because if you are working with a high-end machine and you are using high resolution probe, you will see bright kidneys. So that is normal. Now the classification, which society guidelines to follow. Again, this is very confusing. So these are the different societies using different classification system, which is absolutely difficult to follow. Now this, you read this paper, multidisciplinary consensus on the classification of the prenatal and postnatal UTD. Now this, when we talk about multidisciplinary consensus, this was basically aimed to sort out all the different confusions which were happening regarding the urinary tract dilatation. And these are the 8 different societies which came together, and in a very collaborative manner they formed a system to have more uniformity when we talk about urinary tract dilatation. So these are the standard 8 societies which was involved in this paper, right? Now there are total categories. If you see, there are 3 antenatal categories and there are 4 postnatal categories. I will come to that. And there are 3 ways to go about it. One is descriptive. Descriptive in the sense you say, okay, this mild dilatation, moderate dilatation or severe dilatation, but these are very subjective terms. Then there is objectivity, quantitative measure, where you do a numerical value of renal pelvic diameter as I showed you, and then based on that you say, okay, it is 8 millimeter or it is 10 millimeter. Based on that you give your report. And third is your semi-quantitative, which the Society of Fetal Urology and the European Society uses. But I will tell you which this is Society of Fetal Urology classification. Here grade 1 there is only splitting of the renal sinus. In grade 2 the pelvis is dilated and central calyceal system is dilated. In grade 3 there is dilatation of central as well as the peripheral calyceal system, and in grade 4 there is, apart from the dilatation, there is thinning of the parenchyma also. Okay. Now this is a paper which we are following now, and in this paper if you read the consensus regarding urinary tract dilatation, they have clearly stated that if you use this paper, I mean this concept, it is very reliable because it has got uniformity and consistency. It helps you to risk stratify. Always when we say UTD A1, UTD A2 to 3, low risk, high risk. So this is about risk stratification. And also if you read this paper, they tell you, they give you the recommendation pathway, that if it is this value, next what to do, when to recall the patient, what is the possibility of the that this fetus will need postnatal evaluation, and at what point of postnatal life it needs another scan. So all these details are there in the paper if you read. There are certain drawbacks of this paper. It is not applicable to lower urinary tract obstruction. So if there is posterior urethral valve, and secondary to posterior urethral valve if there is upper urinary tract dilatation, so this paper does not allow you to do that, and there is sometimes over generalization. Okay, and it is applied for UTD alone. That means it is not applicable for ectopic or solitary kidney or multicystic dysplastic kidneys. So we will these are the common descriptors, 6 common descriptors of this paper, like AP diameter, like we were discussing. So AP diameter is already included in this. Then calyceal dilatation, both central and peripheral. Then you will look at the renal parenchymal thickness and renal parenchymal echogenicity. Then you will come down to ureter, and then you will come down to bladder. So these are the 6 things which you will try to see each time when you look at the fetus with urinary tract dilatation. Because when you see all these 6 variables, then only you will be able to classify them and risk triage them, whether it is in low risk category or high risk category, right? So renal AP diameter, we have seen how to measure it. calyceal, I have shown you how to differentiate central from the peripheral calyceal system. So you have to do this mental exercise. Every time you zoom up your image and try to see whether it is central or central plus peripheral. So you will get an idea on how to do parenchymal thickness and echogenicity, and then come down and see the ureter and bladder abnormality.
Parenchymal thickness and echogenicity means abnormal types I'm asking.
Yes.
What are the abnormal things we see in that? And apart from cystic things and those?
Yes, apart from the cystic things, if it is too much of dilatation, there will be thinning of the parenchyma. But in antenatal life, there is no particular threshold. Like postnatal, we have 3 millimeter. There is no threshold that I say, okay, this is thin, but it's subjectively. If it is too much of dilatation of collecting system, we know parenchyma looks thinned out.
When age
Yes.
increases,
Yes.
the pyramids become more prominent.
Yes.
But that is if it is less echogenic, that is a normal part of the syllabus.
Yes. I will show you with case examples. Okay, that will answer your doubts.
Sir, here is another drawback is there. So previous slide, sir.
Yeah.
Sir, if all the criteria are normal,
Yeah.
then if only the anterior posterior renal pelvic diameter is mild,
Yeah.
then UTD1 is diagnosed. In
UTD.
that case also, that may occur due to some bladder distension or backflow of the bladder.
Yes, it may occur. It may occur. That's why it is a good practice to repeat your examination once. Okay.
also.
Yes, here also. Now there are 4 common errors also which may happen. First, measuring pelvis in the sagittal plane. You are not measuring in the correct plane. Next is you are measuring extrarenal pelvis in infants. Okay. Then this is the postnatal. Okay. Infants I am talking about. I am not talking in the fetal life, because in fetal life you cannot differentiate intrarenal and extrarenal pelvis. So in fetal life, when you are measuring, you measure the largest diameter. But when postnatal, you have to measure only the intrarenal pelvis, not the extrarenal pelvis, because extrarenal pelvis may misguide you. Actually, we are following up our cases. That's why we do more often, because whenever there is dilatation, and we call them postnatally, and then again we evaluate. So many a times we see previously, if somebody has seen, they have measured the extrarenal pelvis, so it should not be measured. I will show you with a case examples. Then mistaking medullary pyramids with peripheral calyceal system, that is also one of the trap. And avoid terms like major and minor calyceal system, because this creates confusion. Because what is major calyceal system? Major calyceal system is your central calyceal system, and what is minor? Peripheral. But what is more detrimental? I mean, which is so peripheral. If peripheral is affected, that means you are in UTD 2 to 3, right?
Yes.
But when you say is minor, then it is minor means minor, major means major.
Yes.
But actually it's ulta. Minor is more dangerous than your major. That's why you should avoid this major and minor and talk in central and peripheral calyceal system. Okay. Then this is the chart which we always look at, because many times we forget the cutoffs and then we have to just repeat it and just see. So A1 and 2 to 3. So epirenal diameter based on the gestational age, and then based on the calyceal system, ureter and parenchymal abnormalities. If you are looking at all this and then ticking your boxes, then at the end you know it is UTD A1 or it is UTD A2 to 3. Correct?
So if there is bladder abnormality, then that is, suppose in case of Luto, then this is not applicable at all.
According to the paper which I have cited, if it is Luto, they say they exclude it.
Usually 2 to 3, I used to think when Luto, I used to put in 2 to 3. So that is wrong, or should I not like that?
As per the paper, they exclude it. They say for Luto it is not applicable.
Okay.
That's why I put up that as a dilemma. So that was some learning thing which even I never actually came across. But when I was preparing the talk, okay, so Luto they are not including
Because
in that.
bladder abnormality, and that is mentioned in this
Correct.
classification. But
Correct.
in Luto, we find a dilated bladder with a dilated 2
Yes.
to 3 kind of scenario.
So in that paper they say you should not use. And this UTD A2 to 3, if you look at the postnatal outcome of all this, 60% will have mild hydronephrosis and 20% each will have moderate and severe hydronephrosis. So it is very important to follow all these cases of UTD A2 to 3 in a postnatal period. Okay. Now this is about the postnatal. This is P1, P2 and P3. Okay, these are the postnatal classification. And in the postnatal classification, these are the cutoffs of the epirenal pelvic diameter. So anything more than 10 is abnormal in the postnatal. And calyces, if you look at the calyces, then obviously central is P1, peripheral is P2, and then any dilatation is P3, right? And ureter, again there is in UTD P2 if it is more than 4 millimeter, but mostly ureter we are not measuring it, it's a subjective assessment. We see tortuous dilated ureter, we feel is dilated, and then there's parenchymal abnormalities. So this is the postnatal classification, but if you are not doing the postnatal ultrasound, then you need not worry about this. We are doing postnatal also, that's why we keep looking at this, otherwise not required. So prenatal is sufficient. Now if you look at this case example, look at the kidney, look at the kidney. So this is 19 weeks 1 day case. APRPD right side is 5 millimeter, APRD left kidney is normal, no need to measure. Ureters are normal, and then the parenchymal changes. Look at the parenchymal changes. How many of you believe parenchymal changes, normal, abnormal?
Sir, abdominal TPS.
Tell me.
TPS सब कुछ इकोजेनिक लगता है, काट इकोजेनिक is
Okay. So it is UTD A1 or 2 to 3.
So shall we wait and again do the because 5 is again
Yes. So this is basically, yes, it is a normal kidney. I mean, it's a parenchyma is normal, but just because of the TVS it shows accentuated.
One of the kidney is looking less echogenic than the other. Both should be looking echogenic, na, if doing TVS.
Yes. Yes. Yes.
So you have
to tell me.
Like if this is echogenic, that should also be looking echogenic. If I'm
See, I have already put the answer there. Huh? I have actually put the answer there, parenchymal changes. Huh?
Oh.
So I have not put the answer there to confuse you all. I have put the answer there because it is the right answer actually. It is present. So he has rightly pointed out that one is normal, and there are other clips also, but because of the I have just put 2 clips. So I have looked into detail with all this, and as you have told, abdominally also I have checked it. That is a good idea. Abdominal also I will put here. Now the thing is, this one kidney unilateral, it had that parenchymal echogenicity. It was bad because previously I told you accentuated echogenicity, but that will be there uniformly for both. Now since this was there, so even I had the same kind of doubt, but abdominally also it was showing echogenicity and only one side. Okay, so if this is present, parenchymal problem you are seeing, okay, and then it is 5 millimeter only. Now what should you do? Should you say is A1 or A2 to 3? A2 to 3, okay. Okay, so this was my statement. Right kidney appears echogenic with increased epidiameter. See, UTD A1 I have given. Query, evolving cystic dysplasia. So why I have put this? Because this was prospectively when I was reporting I have done that, but that was my error actually. Later on when I was analyzing my own image, I felt no, it is not then A1, then it should have been A2 to 3. So what happens, your own reporting and your own work which you have done, later on when you analyze, you will feel there is some lacunae there which you need to plug in. That's why I have kept both the things, one present and then I am contradicting myself there, because this happens in the real life situation. So this was one learning point. Okay, so answer is 2 to 3, not A1, correct? Now again have a go at it. This is one kidney. So APRPD 6 millimeter, 8 millimeters, ureter normal, parenchymal changes, none. Now you see both the kidneys are echogenic. So 6 millimeter and 8 millimeter. But this accentuated echogenicity was because of the high frequency probe. Okay. Now again this one, just you see, this is something different. AP diameter of the left renal pelvis 25 millimeter, 22 millimeter in right, and both central and peripheral calcium system dilated. Can you see this? And can you see the ureters? How are the ureters? Dilated or normal? Dilated. Dilated. So ureter is dilated. You can see that tortuous thing which is going across. So this is dilated, and bladder also appeared thickened. So now this is
So what is the significance?
not applicable because it was because of the luto, bladder and ureteral changes precedes renal changes. So if it is because of the luto, bladder is thickened. So probably, and I will show you this, gender was also male. So probably because of the posterior urethral valve, and if your bladder changes are there, thickened bladder wall, that means ki it's mostly because of the luto. So because of lower urinary tract obstruction you are getting bladder, and because of the bladder changes you are getting upstream changes. So in real sense, if you read the paper, you will not include them because it is not applicable. But however, most of the time we are not aware of that, and we will report as UTD A223. That was your question, na, Deblina? I mean, we have done the same thing, but this was something insightful, that if it is luto, then this is not applicable, right? Now these are the postnatal classification. Okay, this is normal because this renal pelvis is just 4 millimeter, and these ones are not calyceal system, these are medullary pyramids. These are medullary pyramids. Okay, now if you look at this, there is renal pelvis, and then this is what? This slide from renal pelvis is central calyceal system. Okay, so this is P1. Now from central calyceal system it is going inside, so this is peripheral calyceal system. Okay, and then there is parenchymal changes in the form of thinning, or in the form of echogenicity, or in the form of multiple cystic changes. So this is postnatal classification. Now risk these are the risk stratification. If it is within the normal range, we need not worry, normal follow-up. But if it is UTD A1, in all those cases of UTD A1, we have to repeat ultrasound at or near 32 weeks. Now there is a problem here, that we see at 24 weeks, suppose, and then we again ask them to come back after 2 weeks or after 3 weeks. It makes no sense, because what are you going to do? You are not going to deliver, you are not going to treat. So better to again call them back at 32 weeks. Give it some time. You need not see it every 2 weekly or every 3 weekly, nothing will change. So at 32 weeks, and repeat is not needed if dilatation was first detected after 28 weeks. So if after 28 weeks, then even you may not see at 32 weeks, later on you can see. And these are all low risk. So initial postnatal ultrasound is within 1 to 3 months. These are all low risk category. So you can tell them to come back after 1 month or after 2 months of the delivery. But in high risk category 2 to 3, your repeat ultrasound at or near 32 weeks or in 4 to 6 weeks, whichever is later. Okay, so suppose I have seen the case at 24 weeks, and if it is high risk, then I have to call them back at 28 weeks, 4 to 6 weeks or 32 weeks. So 32 weeks means 32 weeks you have to call, which is later. So 32 weeks is later, you have to call at 32 weeks. So most of the time repeat ultrasound has to be done at 32 weeks. Okay, And this duplex and anomalous kidneys, this you can forget at this point of time. And high risk categories, the ultrasound, first ultrasound will be done on day 7 of delivery, and then the second ultrasound at 1 to 3 months. Okay. Now this case came as a second opinion for intra-abdominal cyst. Okay, just see this second opinion for intra-abdominal cyst. Are you able to see the cyst there? You see the cyst there? And then when I was scanning this case, I was just wondering what is the location of the cyst, why this, and then what is below the cyst. There's something below the cyst. You see this? Renal pelvis? Then how come the cyst will be above the kidney on the capsule?
Urinoma.
Yes, fantastic. So this was a case of perinephric urinoma, because Saheli, if you see here, this renal pelvis is there, fine, okay, and cyst is on top. So because of the hydronephrotic changes, you are seeing dilated collecting system there, and if that dilated collecting system ruptures or give way, there will be loculated collection. So this was a case of urinoma, perinephric urinoma, just on the capsule of this dilated collecting system of the side of the kidney, but it is not a any kind of intra-abdominal cyst. On the left side this was, you can see the stomach also intermittently coming. So are you getting me? So these are the things sometimes you have to have in your mind. The prognosis, actually we did not follow up. I'm not having the outcome based information, but what I read during that point of time, that most of the time is a kind of safety valve mechanism which prevents the kidney from further damage. So this urinoma, but I think this perinephric urinoma, if it is growing, then they have to decompress it. We will take a follow up of this case to see how the things are. Now this is at 35 weeks, right kidney enlarged echogenic, showing multiple non-communicating cysts of variable sizes. Okay, and renal parenchyma echogenic corticomedullary differentiation. So this is, what is the diagnosis for this? So this is plain simple multicystic dysplastic kidney. Why I have put here? Because sometimes you need to differentiate multicystic dysplastic kidney with urinary tract dilatation also, because when the calyceal system, everything balloons up dilated, it may appear, but in those cases there will be communication, and in these cases when you see the different locules, they will not be communicating with each other. So these are, that's why we have to put all this language, non-communicating cystic kidney. So this itself explains for multicystic dysplastic kidney. Now look at this case, 22 weeks 6 days. What do you see? Again there are multiple cysts. Are they communicating, non-communicating? Non-communicating? Fine. So that was also one of the case of multicystic dysplastic kidney. Now what are the clues to etiology? Signs to narrow down the differential diagnosis. So clues to etiology is, once you see a dilated collecting system, try to at least attempt to see what is the probable level of obstruction. If you are seeing only dilated collecting system, ballooned up collecting system, but ureter is not at all seen in yours, then you know obstruction is somewhere very proximal, probably at the level of the UPJ, uretropelvic junction obstruction, probable. Okay. But if you see ureter dilated along with collecting system, or even ureter is dilated, tortuous, then you should suspect obstruction at the lower level. Might be at the level of vesico-ureteric junction, or might be even at the level of the bladder neck, urethra, or whatever. Now this is something very new which I got. In this, what is the CPU of the kidney? CPU, central processing unit. So CPU here stands for calyx, pelvis and ureter. So this is the outflow tract of the kidney. Like in heart we have outflow tract, we have an outflow tract for the kidney also, and this is the CPU of the kidney. Now there is a pacemaker in kidney as well. Like in heart there is a pacemaker in kidney, and this pacemaker in kidney lies in the peripheral calyceal system. Okay, peripheral calyceal system. And this renal outflow tract pacemaker is actually hyperpolarizing activated cation channels. So what this does is, there is a special myocytes there, and this special myocytes, they trigger peristaltic activities which is conducted from proximal to distal. And when that it's conducted from proximal to distal, there it will, what it does, it will propel the urine from the production site along the pipeline to the collection site to the bladder, because it has to go in an antegrade way, right? There is a production here. Now how does the production knows which direction I have to go? So this pacemaker, this hyperpolarizing activated cation channels, they send a signals to these myocytes, okay, they should contract, and once they contract, the urine from this collecting system goes into this pelvis, and from pelvis to ureter, and from ureter to the bladder. Now if there is crossing vessels which compresses them, it may cause obstruction. If there is any structural or mechanical obstruction, then again there will be stagnation. If there is abnormal smooth muscles which is not functioning, again there will be stagnation. Or there is absence of pacemaker cells, again that will cause stagnations. And why these all four things are important? Because these four things are the major ingredient for idiopathic functional obstruction. Because many of the times obstructions are functional, it is not mechanical, and we fail to explain why these are so. So these are the four reasons most of the time they are functional obstructions. There is nothing in between, there is no obstruction as well, mechanical obstruction, but because of all this there may be sometimes functional obstruction. Now we will come back to, we will deal one by one few of them, the common ones. One is the uretropelvic junction obstruction. So in this uretropelvic junction obstruction, important thing is 90%, more than 90% are functional. They are not true anatomical, they are functional actually. And 50% of the patients will have other urological abnormalities like contralateral obstruction or vesico-ureteric reflex, and up to 50% of this patient will require intervention because of worsening hydronephrosis or decreasing renal function. So whenever you talk to the patient about the UPJ obstruction, you have to tell them these figures, that 50% or half of them, they may require pyeloplasty surgery, right? And you have to look at the contralateral kidney very carefully, because there may be associated reflux in the contralateral kidney as well. You have to look at very carefully. And sometimes persistent PUJ may cause back pressure changes in the kidney and transform into like appearance of multicystic dysplastic kidney. This is a Mickey Mouse sign which you will see because of the dilated renal pelvis and dilated central calyceal system. Okay. Now again, I will not go into detail. This may be, PUJ may be primary, secondary, but forget about it. In fetal life, mostly it's because of the ureteric folds. And in infant or newborn, it is because of the stenosis. And in childhood and adolescence, is because of the extrinsic obstruction. So when we say about the PUJ obstruction in the fetal life, it is mainly because of the ureteric folds. And that is the reason they are self-limiting. And if that stretches out, then automatically there will be clearance. But we have to warn them that if it is persistent, then there is high chances that this fetus may require postnatal surgery at some point of time. Now this is just a case example to show you. If you look at a glance, this appears like a bladder. If just you put your probe, it looks like there's some megacyst or something, but it is not that. You go to the coronal section and then you see ballooning of the renal pelvis, and then there is sudden abrupt tapering. You will not be able to see any ureter, and then there is dilatation of your peripheral calyceal system also, which is shown in this picture. Then coming on to the VUJ obstruction. VUJ obstruction is just obstruction at the level of the vesico-ureteric junction. Okay. Now just I will show you the picture. Now can you see the ureters there? Just like a snake like. Okay. So these are ureters. So if you are seeing dilated collecting system with ureters also prominent, then you should suspect obstruction at the level of the VUJ, or it may be just a vesico-ureteric reflex also. But in prenatal life, in antenatal life, it is very difficult to say exactly about the nature of the obstruction, exactly what is the level. So probably you can just put in a line that obstruction may be at the level of the VUJ obstruction, I mean at the level of the VUJ, and then later on postnatally it can be evaluated. Now a few words about the vesico-ureteric reflex. Now you know about all this. Initially the reflex will be just into the ureter, then it will be transmitted into the calyceal system, and then your parenchyma will suffer. So this is just a scheme to show you. Okay, I'll not go into detail of the VUR, but the important concept is what is primary and secondary VUR. Now primary VUR is your anatomical reasons, because of the anatomical reasons. That means normally when the ureter is inserted into the bladder, there is an oblique course into the bladder, and that oblique course into the bladder is such that if the intravesical pressure rises, that acts as a safety valve, and pressure is not transmitted into the ureter. It goes like an oblique tunnel like course. So that is a safety valve. If that is distorted, the pressure, back pressure changes will happen in the ureter. Each time the bladder is distended, pressure is high, there will be transmission of the pressure into the ureter. Okay. And also this primary vesico-ureteric reflex may sometimes be familial. Sometimes they are familial. And why they are familial? Because of mutation in the PAX2 gene. There is a gene, PAX2 gene, which leads to renal coloboma syndrome. What is renal coloboma syndrome? Is vesico-ureteric reflex or any kind of dysplastic changes in the kidney plus optic nerve coloboma plus sensorineural hearing loss. Okay? And secondary VUR is just because of the pressure changes in the bladder, elevated intravesical pressure, as in neuropathic bladder or posterior urethral valve, and once it is transmitted, it causes. But we cannot differentiate primary from secondary. This is just a theoretical understanding what I am talking about. But if you see a case, like I'll show you, this case at 21 weeks 3 days, can you see ureter dilated, kidney dilated? Now this mother had herself twice ureteric reimplantation surgery because of the reflex. She had reflex and twice there was ureteric reimplantation. And her one of the first child also had VUR, diagnosed with VUR on MCU, micturating cystourethropy, and she is on antibiotic prophylaxis, right? On antibiotic prophylaxis. And now this pregnancy also I am seeing this dilated ureter with collecting system. So if you are aware of the familial predilection, then you can correlate. Obviously it's very difficult for them to do a genetic analysis and PAX2 gene and what. We did not do that. Actually that time I was not aware of that also. But this is something like we have to keep in mind when we see dilated collecting system, I mean the kidney, ureter and everything. We can ask the history or even screen the mother's kidney to see if it is not one of those familial cases of vesico-ureteric reflex, right? Now ureterocele, I don't know how many of you have seen ureterocele, but I will show you the picture of the ureterocele. You see in the bladder there is a balloon like, there is a cyst like thing in the bladder. This is ureterocele. Now once you see ureterocele, you will go back and see the kidneys and you will try to rule out duplex collecting system. Okay? So duplex collecting system, you have two moieties in the kidney, upper moiety and lower moiety. So ureterocele will be associated with upper moiety or lower moiety? upper moiety. So you upper and you uretrocele. Okay. So this is the duplex collecting system. Okay, and you see this on the scheme, you see the upper pole is because the hydronephrotic, I mean this dilatation is because of the uretrocele, right?
So why upper moiety?
That we don't know, but mostly and I will give you just one more hint, that whenever you look at duplex collecting system, you will feel the kidney is little bit enlarged. It will be more than 95th percentile. Okay, and this is just to show you how the duplex collecting system works. This is just ectopic insertion, yes, and I'll just show you two aspects of it. One is Wiggott-Mayer principle and other is Mackay-Stephens principle. Now Wiggott-Mayer principle is basically this upper pole renal mass. It drains through the ectopic ureter and infерomedially. Can you see this? Upper pole renal mass drains inferomedially, and lower pole renal mass, it drains through normal orifice. So ectopic insertion is always the upper pole. Lower pole, I mean the lower moiety, it drains to the normal ureteric orifice. And why this is important? Because of this Mackay-Stephens principle. What it says is, there is, if your ureteric bud can be at the level of A, B or C. So this is normal ureteric bud, I mean normal level B, this trigone, and at this point there will be a maximum number of metanephros. So if there is maximum number of metanephros, this region will be more differentiated than the other two regions, A and C. So if these regions are not very well differentiated, they will always be abnormal. There will always be abnormal. So see the results of this A, the trigone, this is abnormal, and then again budding at C is abnormal, but B is normal. So these are theoretical things, but what take home point I want to give you, whenever there is uretrocele, look at the kidney, and mostly the upper pole moiety will show you dilated collecting system, and if your lower pole is showing dilated collecting system, then it is mostly because of the reflux. It's mostly because of the reflux. This is again the uretrocele. That's the measurement of the uretrocele and the ureter. Now this is antenatal and postnatal. This, I think, a glimpse I have given you already. When to follow up. So UTD A1, we are doing additional ultrasound at 32 weeks, and UTD A2 to 3, most of the time we are following up in 4 to 6 weeks. And after birth, this is the regime, and also aneuploidy risk modification. You have to do, you have to risk calculate for the aneuploidy. That I will show you how to do in the genetic workup. In genetic workup, just I think we are left with few things. These are the soft markers in the second trimester, and in one of them you have this mild pelvic ptesis. Okay. Okay. So this is the Excel sheet. This is the dynamic calculator which you all can download and see. If it is only, see, echogenic intracardiac focus is present. Okay. If it is only as isolated marker, LR of combination is 0.95. If you have this echogenic intracardiac and on top of that you have mild hydronephrosis, then your LR of combination goes to 8. So the take home point is, whenever you see pelvic ptesis, you understand that is one of the soft markers. So look at all the other markers very carefully, and then you go to this calculator, and based on that you tick whatever is present and whatever is absent, and you will get a LR of combination. Based on that you may modify your risk. So just don't jump when you see a dilated collecting system or pelvic ptesis. Now you know it is just 1 likelihood ratio, so 1 will not change my risk anyways, so I dismiss it off. Don't do that. You look at all the other markers as I have shown you in the previous, and then just tick box everything, recalculate in the calculator, and then you assess the risk. Okay, it happens. Like recently we were seeing a case where there's just echogenic intracardiac focus, very benign, nothing to, but then on more examination I saw there is aberrant right subclavian artery. So if there's echogenic intracardiac plus aberrant right subclavian artery, then your LR will change. So be very careful with this. Look at all the markers and then you come to your conclusion. Okay. Now, does the laterality matters? So not really. There are a lot of studies on that. Still controversial. And does the gender matters? So gender, yes, there is certain issues in the gender. But if we see always whenever there is a dilated collecting system, we should look at the gender. And if it is a male gender and then there is a bladder abnormality, then we suspect most likely secondary to the lower urinary tract obstruction than anything else. So later on we can discuss this, otherwise it will become too heavy. So this was few of the dilemmas. Hope you people are too confused now.
Sir, if luto is there, gender is male or female. In that case, like if it's male, we will give that as posterior rectal valve, or we will.
I will discuss this. I will discuss this. Luto I have discussed separately. Luto. Okay, there is a separate talk on luto. I will do that. But what is the question I'll answer?
If luto is there, we'll see male or female.
Huh.
We'll see male, then it's a posterior rectal valve. If it's female, it's going to be urinary.
And that's the problem. That is the problem. That's why when I presented my luto, I tried to clarify it. Because your posterior urethral valve, we presume it's posterior urethral valve. We presume. And keyhole sign is also not specific to posterior urethral valve. It is in 50 to 60% of the cases only. So what we have to tell, irrespective of the gender, we have to say that it's only lower urinary tract obstruction and we need to investigate further. The biggest mistake is we see the gender and then we jump into that, okay, this is a keyhole plus male gender, so it's posterior urethral valve.
So you just mentioned in the report that it's a
Yes, it is a lower urinary tract obstruction and with these changes and describe this. That's it. Don't at all write posterior urethral valve, because that only is a cystoscopic diagnosis. When we do fetoscopic cystoscopy to see, then only we will be able to say it is a posterior urethral valve or it is some kind of urethral stenosis or urethral atresia. Okay, so that is one word of caution always.
So then prognosticating, like
In cases of luto, luto is a separate talk. I will do that. I have lot of slides on luto. I will do that. I don't mix this luto and urinary tract dilatation.
Sir, everything comes under cacut or
Manifestation. No, Kakut is a blanket statement.
Okay.
Kakut is congenital abnormality of kidney and urinary tract. Now they say even synonym of Kakut is UTM, urinary tract malformations. In that, one of them is your urinary tract dilatation. Then there are multiple things in this.
Sir, like in DTD 1 you said it is less around 4 or this case we will not call for repeated scan. In 2 to 3, sir, how to prognosticate again and how to counsel the patients with? What shall we tell regarding the
In 2 to 3.
2 to 3?
Yes. In 2 to 3 we will be following up 4 to 6 weekly. That is separate, prenatal life. We will see how the things are progressing and based on that we will say whether it is progressing or remaining stable, whatever. Postnatally we have to call them back in a week time for a scan, not immediately after birth, because there will be physiological dehydration will be there in the baby. So we will call them back possibly after 48 hours, after 48 to 72 hours, just to see what is the status of the kidney.
What is the usual prognosis from your experience in postnatal cases in 2 to 3? What really happens and how many go for surgical intervention if any?
See, the prognosis will depend upon the radionuclide scan. So always when we scan postnatally and we see a very weird picture of renal collecting system very much dilated and looking very ominous, always we have to ask them, and they go for a radionuclide scan, because the doctor also knows that prognostication has begun. Now radionuclide scans also, there are a few slides I will discuss with you. These are the functional assessment. There is a DTPA scan and DMSA scan. Okay, they have got two different implications. DTPA will tell about the split renal function, GFR, and DMSA will tell about the anatomy and the functional obstructions. So combined, they will give you a risk estimation that, okay, right kidney, this is the percentage of function, left kidney, this is the percentage of function.
So a basic question, non-affording patient, if she asks, I want to go for termination based on this, do we allow that, or we?
The problem is that the same thing we were discussing in Fetal Vision with Suresh sir. Now the biggest problem with the kidney is just like the brain. We don't know how much nephron or how much neurons are already damaged, because the earlier the insult, it affects the nephrogenesis phase, and these are irreversible changes. So even if we are intervening in the prenatal life, we are not sure that how much nephrons is already damaged. Okay, so as coming back to your question in a very simple plain language, we will tell we don't know. We don't know because we can only look at the structure, we cannot look at the function, and most of the time we have seen there is discordance of the structure and function. We see a very weird looking kidney, but postnatally when the functional assessment has been done, it shows renal split renal function 46%, 48%, which was not at all expected. We were expecting somewhere 10%, 8%, but it has come like that. And sometimes on the other side, it is not showing that bad, but renal function is very poor. So there is discordance there also. So what I tell to the patient is, to be on the optimistic side, let us go ahead with this journey, deliver it, proper postnatal care assessment with a urologist who deals with these cases, and then plan their postnatal pathway based on the ultrasound and based on the radionuclide scan. What are they going to do with this? And then, because the radionuclide scan will also give you an idea that is this a kind of functional obstruction or there is a structural abnormalities. If suppose there is any kind of stricture at the level of the PUJ or the level of the VUJ, then if they remove the stricture, they will be fine. But if it is because of the functional obstruction, then they have the different ways to circumvent that. They do pyeloplasties and different ureteric reimplantations and other things. But I have seen few of my patients, they're going to Bangalore and going to dedicated units and getting treatment and coming back. But we don't have long-term follow-ups. So I would suggest that you people, when you are seeing it, make it a habit to have a follow-up of these cases. Not short-term follow-ups, long-term follow-ups also. Short-term follow-ups will not yield much information. At the most, they will give you that radionuclide scan ka picture and yes, sir. But post long-term, how the baby is doing, that is very important.
So also another thing, the implications of genetic tests for malaria. Which are the scenarios you ask for genetic test here?
Number one, if there is associated abnormality, suppose you get whatever urinary dilatation plus something else, then obviously it makes sense. If it is very severe category, mostly those are because of the bladder outflow tract obstruction or somewhere obstruction down the line, they will not yield any information. They will not yield any information. I'll come back to that. Those cases where there is obstruction, where they are using dilatation and you see echogenic renal parenchyma, hyperechogenic kidney like one of my case, you see echogenic kidney with dilated collecting system. Even if it is mild, you must offer them genetic and that too genetic exome, because your answer lies there. One is ciliopathy and other is your HNF1 beta, that 17q.
17q.
That is,
there was one case of
yes.
17q last week.
That is same thing as HNF1 beta. So you will get answer by that. So hyperechogenic kidneys, there's a paper also recent, HEK, hyperechogenic kidney plus dilated collecting system, you must push them for genetic investigation, especially exome. But if it is not so, there is not too much of incremental yield. And revision of the risk calculation for soft markers anyway. ठीक है, चलो, थैंक यू।